Hope everything is going well. This is for um, chapter 16 here, and for us in class, for our Exercise Leadership 1 class, this is going to be the last chapter of the course. So this is going to be the last video recording that you'll have to worry about in terms of test-taking purposes, so pay attention here. In terms of concepts, this is talking about chronic health conditions and physical or functional limitations, but really what we're talking about here is more about the special populations component, and that special populations mean that those that might be either a little bit more at risk for certain things, those that might require more attention, those that might require us to be a little bit more modifiable in terms of what we can do. Okay, so let's kind of go through here and kind of go through what can happen with different folks that might require us to do different things. All right. First thing is age, and the first thing that we kind of get on is the children topic. So we want to make sure that we can understand that there are physiological differences that do occur with them. There are certain things that just do not mature, particularly muscles, blood vessels, the lungs. They're just not as effective and they're not as efficient in working as what an adult has, and so that's one of the problems that we run into is that you try to work with children like you would like a little adult, and it just doesn't work that way. Okay, so the on this slide here, what we're talking about is the physiological difference of what we just said already. The next thing to kind of understand is there's a term called peak oxygen uptake versus what is comparable to max VO2 or maximal oxygen uptake. Okay, so peak VO2 or peak oxygen uptake basically is where muscular fatigue occurs before a person actually achieves a maximal level. So what you'll end up with is muscle stoppage versus actually having to stop because you are having a hard time breathing. The intensity of it was too difficult. You feel like your heart's going to explode, whatever that feeling might be. And that's usually, or you just have to naturally stop, but it's not because of muscle. It's not because your muscles are getting fatigued. It's because there's a different parameter that's causing you to stop. And that's the difference between the two. Peak oxygen uptake, muscularly fatigued, maximum VO2, that's usually something with the cardiorespiratory system that usually causes an effect there. Okay? Children are less efficient and they exercise at higher intensities of their maximum VO2. Now, we're not saying max VO2, but the highest level of VO2 they can achieve. So what we're saying here is that children are less efficient. If you were to make them run a mile and they're very well off in doing what they do, okay, and you have them run against an adult who is very good at what they do, or they're very comparable in health status or whatever you want to say, a child will naturally be less efficient, meaning that, number one, their heart and their lungs and the communication between the two is not as mature. Blood vessels allowing blood to flow through, not as mature. Oxygen extraction or pulling oxygen out of the blood into the working muscles is not as efficient. So there's a lot of things that come into play that cause a child to just not have as high of a performance even versus an adult who is at the same health level. Okay, and then of course children, they work at a higher intensity of their maximum VO2. Yeah, that just means that in general children do work at a higher intensity simply because the fact that their body is their metabolism is high, their VO2 is not as high, and so because of that they're working at a higher level, but it's so close to their maximal effort that it makes it very, very challenging for them to continue doing what they're doing. Okay. Children do not produce enough glycolytic enzymes or enzymes that help to break down glycogen to glucose to then be able to use that glucose in working muscles to be able to sustain high intensity exercise. And that's usually typically the reason why. So if you're trying to do high intensity exercise like sprints or something like that, they're going to need more recovery and they're not going to be able to do as many bouts versus an adult. Okay. And so we need to be able to understand that it's enzymatic. It's not so much that it's muscle, it's enzyme, and that's causing that problem there. And then lastly, children are not as efficient at thermoregulation. Now, being here in Florida, um, it's hot for, I mean, let's say 9 or 10 months out of the year, and we actually get a slight reprieve for two, roughly. I mean, it might be a little bit off, but whatever. Um, Children become acclimated, but they just still do not achieve a higher thermoregulation, or they cannot function as well in heat, and they cannot dissipate heat as well as an adult can. That's why whenever you hear things like weather advisories for air quality and typical or heat advisories, children cannot tolerate heat as well, nor can older adults. So that's usually typically the two individuals groupings that are usually under advisory at that point. So you have to be aware of that, especially here in Florida, we have to really pay attention to what's the temperature, what's the weather, what's the humidity. All of that can come into play because it's going to be more challenging for a child to be able to dissipate heat, and they can only sweat so much before they stop sweating. And then you talk about heat related illnesses and potentially death because of that. And it's not something to joke around about. It's very, very serious. So all these things need to be taken into consideration when working with children. Now, with resistance training, there's always been, and I don't think it's so much anymore, but there's always been this misconception that resistance training with children should not occur. Well, no, that's not true. The whole advent that it's going to stunt their growth, it's not going to, it's going to be more trying on their system, and it's not going to make them mature better. That's a farce. If anything, it helps children to maintain activity throughout the life cycle. It helps them to be able to decrease the amount of injury that they might have. It might make it so that, um, you know, they're just able to achieve more because they can move better. Okay, so with what we're talking about here, though, yeah, there's a lower risk of injury than most sports in which youth commonly participate. So, what are we saying there? That when we lift weights, we're not as injury prone than if we were to play soccer, baseball, basketball, football, whatever. Okay. Um, but typically, with sport, you're talking about knee issues, ankle issues, shoulder issues, back issues. Most common injuries are sprains to ligaments or muscle strains. So you're talking about maybe rolling an ankle, or might be a little bit of a tweak with a ligament, might be a little bit more of a strain because you might be trying a little bit too hard. But children sometimes don't understand, or youth don't really understand how to push and how to hold back. So that's how the learning process occurs. But these are mild or not even close to moderate, injuries that can happen versus if you're playing a sport, which can be major to severe. Okay. And then because of resistance training, you're able to, build strength. Initially, it's nervous system that changes, but eventually the strength will come from it. And then obviously, because it's weight bearing for a lot of things with resistance training, you're going to increase bone density, but you're not going to get that hypertrophy base. Okay, you're not going to get huge levels of muscle mass gain with a child, with a youth, that you might think, but it's going to be more strength based and more bone based, which is still going to help them to be able to mature and then still be more active in the future. Or they may just end up being more prone, or they would be less prone to injury as they age as well. Now, these are some recommendations or guidelines that you can do. Um, Everybody has their own interpretation of how much, but obviously the bottom line here is, looking through everything, modes of training are very much the same. There's not really much difference of what they can and cannot do. You walk into some gyms and just fitness facilities around the country, and you got kids working out, which is great. You walk into strength and conditioning facilities, and you got kids working out in there, which is great. You have kids working out in CrossFit gyms, and they're being heavily supervised in there, which is great. So the mode isn't really the main thing. It's going to be okay. Well, their frequency, yeah, they're kids. They have a ton of energy. Frequency is going to be up. How their duration very similar to adults. I mean, adults, it's we try to get them 60 minutes a day if possible, but 60 to 90 is optimal. But 30 is the recommendation. They want kids 60 minutes. Okay, cool. Intensity wise, moderate to vigorous, no different than an adult. Um, with the assessments, it's still very much the same. Okay, still want them to be able to do that, and then they have a push up assessment in there. Flexibility, stay within the adult range. There's nothing. Kids are a little bit more mobile. They have a little bit more laxity in their joints because they still haven't become fully developed yet. So you got to be still pay attention to that. But keep them on that flexibility continuum, and then what resistance training is more of the ones that we want to pay attention to. But they're really set on phase one, stabilization phase being that one that they really want kids to hang out in until they start becoming more matured. Okay. Um, so really, it just depends on the person. If they are able to show you that they have good body awareness, they have good postural control, they have great stabilization throughout the system, then we can give them different things that they can do. But either way, I think that the bottom line here is if you look at the very last word of this chart, it's fun. Yeah, what you're doing with them is going to have to be fun, and it's going to be engaging. It's going to be something they want to come back to do. Because if not, they're going to go. Okay. Uh, with seniors, it's almost like a whirlwind because you have your children, you go through your adulthood, and then you almost kind of revert to being a child again in some way because you start to develop all these symptoms or illnesses or weakenings, and you kind of almost go back to being a child again because you're kind of in that same boat of risk. Okay. But I know it sounds kind of weird to say that, but it is kind of true in some way because it's almost like the maturation has declined to almost where you're like growing up again. But the problem that occurs though is if you look like chronic diseases are going to be more prevalent. Um, obviously the immune system can become compromised, so you might be more apt to disease or illness, more sickness, whatever you want to call it. So you just got to be very careful. That's why exercise comes into play very handily here because of the fact that exercise does promote a better immune system. It creates better metabolic functioning. It creates a better movement pattern. You feel better. You breathe better. So you can supply oxygen better. So there's just a lot of good things that come from being able to just stay active at that point. All right. Um, so with senior adults here, some of the normal physiological and functional changes are the following: maximal attainable heart rate. You just can't get your heart rate up to that high. Cardiac output, or the amount of blood pumped out of the heart per minute, is going to diminish. Okay, regardless, it's with age. That's what happens. Okay, muscle mass atrophy. It's again, it's a natural process. So one of the things that we have to always relate to when we talk about this is we have to understand that if if you don't use it, you lose it mentality is true. So with whatever muscle mass that elderly or senior adults have, they want to try to optimize it as much as possible. That's really one of the main functions here. All right, they're going to lose balance and coordination, or as they say here, neuromuscular efficiency. So you got to try to keep it optimized as much as possible. So you have to try as hard as you can to make sure that that works. Connective tissue elasticity, it starts becoming more rigid, so you're more prone to injury, and it's actually harder to move. So that's why flexibility can sometimes go down. And then bone mineral density, you're more susceptible to osteoporosis. So getting a DEXA scan, as you start getting older, is going to be optimal, and then constantly staying up on that every year or so to see if you are having deteriorations is going to be very critical. All right. Now they have different things here. Again, the mode changes. Frequency goes down versus a child. The intensity, it's 40 to 85% of VO2 peak because they're not going to achieve a maximal VO2 at that age because they're past their peak. They say 30 to 60 minutes here, 8 to 10 minute bouts, which sometimes can be more beneficial depending upon their health status. The moving assessments definitely are a lot less independent. All right, so you got to be aware of that. They want you doing some, self myofascial release and static stretching more so than the dynamic. All right, and then there is again, phase one is going to be optimized. Phases 2 to 5, they kind of want you to, again, if an older adult can show that they're capable of postural control, again, functioning on their own, then we can give them more. But a lot of times, yeah, physicians approval might be there too. So, and then they give you some considerations like progression. Um, is definitely going to be optimal because it's going to have to be showing you how they go from uh, more stabilized things to less stabilized things, and that's really what it comes down to. I mean, you're talking about anything from sitting in a chair correctly to standing up out of that chair correctly to then standing up on their own, like in a squatted position. So it's a lot of things that can come into play there. And then one of the things that they have to understand is breathing and how to understand how to control the diaphragm so that, they say the Valsalva maneuver, or basically you're stopping your breathing. Well, that can make them pass out pretty quickly just because their system can't tolerate that. Okay. Obesity, okay, another special population, and it's a growing issue still. Really hasn't been any signs of slowing. So when we look at everything here, it still is the fastest growing health problem in America. Yeah. Okay, yeah. So yeah, 66% of Americans older than the age of 20 are overweight, and of those about 34% are obese. Now, that's over the age of 20. The overall numbers are, I believe it's 36% are obese and 67% are overweight. So you have 67% that are overweight, 34% that are obese. So it's a pretty big number. It shows you how unhealthy people really are. Okay. They give you some BMI numbers, which is it's basically the comparison of your weight compared to your height, squared. Okay. And it gives you a kind of like a ratio number. Um, it's not a percentage. It's not body fat percentage. It's just a comparative ratio of your weight to your height. And if you fall in those categories, you can see there that it's really truly below 18 to 24 and 24.9 is normal, 25 to 29.9 is overweight, and over 30 is obese. And they have three categories of obesity, which are obese 1, 2, and 3 on 5-point increments, and then actually below 18. Typically, this scale is a little bit skewed because a lot of textbooks and author written research, shows 18.5 is the actual number. Then anything below 18.5 is considered underweight, which can have just as many negative consequences as being overweight or obese. Okay. Um, what happens with obesity? I mean, obviously, obesity is a lifestyle factor. There isn't a lot that has made me feel like a lot of things that are seen in, with that's written and what science has shown is that there really isn't as much of a genetic predisposition for people when it comes to obesity. Like, if you come from an obese family, it's not destined to be where you're going to be obese. So that's something that we have to understand, is that you can't blame it on genetics. Now, can there be some genetic underlyings that can, maybe a thyroid condition, or maybe you just don't have a high metabolism in general? I mean, any of those things can make a difference. So um, it just depends, but it's not because your mom was a obese woman. It's not because your dad was an obese man. It's not like that. There's other factors that come into play with that, and typically, usually, it is lifestyle, or lack of dietary approaches and lack of activity or exercise. Okay, so where do we want our people to be? Phase one, phase two. Okay, we we want them to be more stable, and then once we can get them to be stable, we can get them to start moving more and start building up some sort of strength base if possible. Okay, and with phase two, with that muscular endurance, you're doing a lot of superset based things, so it's going to increase metabolic, the metabolic burning that affects, the ability to take calories and diminish them. Okay, so again, one of the things, it says slow and gradual weight loss. Well, yes, but you also need to, if you're doing things correctly and you're not going to the extremes, if a person who is severely obese loses 10 pounds in a week, what we need to understand is that that 10-pound weight loss was appropriate for that moment because you weren't doing anything that was out of the ordinary and you weren't giving them things that were making it, like I said, to the extreme. So you might have, one week it might be a little bit, the next week it might be 10 pounds, the next week it might be a pound, the next week it might be 4 pounds. So to lose 100 pounds in 2 months is, that's substantial. That's unhealthy because the body has to be able to recover and kind of work with what it's doing. It has to be able to change with the changes of the weight that's being taken off. So it's just very, very challenging. But you need to understand that weight loss it's going to happen the way the body wants it to, and if you're doing it correctly without anything extreme, like I'm saying, then it's going to do what it's going to do and it's going to react the way it's going to react. So that's okay. All right. With overweight and obese people, a lot of times, like it says here, low impact or step aerobics can be very appropriate. There's nothing wrong with resistance training here. We want them to be able to just start getting healthier, and that's going to be optimal at that point. Um, Other changes, yeah, 40 to 60 minutes per day versus the 60 minutes per day for kids or adults. So, we can do assessments, but it's only if it's tolerated. And then we want one of the things because they're going to be moving more, they're going to be sore more. We want them to be able to do self myofascial release, but we also want them to be on the flexibility continuum as much as possible. So we definitely want that to occur at some way. So with resistance training, again, 2 to 3 days per week to offset the cardio that they're doing. So it just, we want them to progress in a manner that works, but we want to keep them active, and that's going to be very, very appropriate for that point there. Okay, but they have to start getting aware of their body. They have to start getting comfortable and more realistic to knowing more things. So it's just going to be a change for them. With diabetes, type 1, type 2, I believe, if I'm not mistaken, I think for the types, I think it says here the seventh leading cause of death in the U.S. I think it's 92% of diabetics are type 2 and 8% of diabetics are type 1. Okay. And then on top of that, because type 1 is, juvenile diabetes, whereas type 2 is adult onset, there's about 23.5 million, almost 24 million children that do have type 1 diabetes. That can be anything from environmental exposures to just, to having an illness or sickness at birth. There's a lot of factors that can come into play that can cause this early on. And typically, the development of type 1 diabetes goes usually about, I think the main number is about up to the age of 10 is where they can start developing it when it's considered type 1. Now, type 1, insulin dependent, type 2, non-insulin dependent, which means that type 1 need insulin to be pumped into their system, whereas type 2 is, if you put insulin in there, it may not work at all. Okay, so it just depends on what type. Now, normally, like it says on the bottom there, exercise is going to improve type 2 diabetes simply because of the fact that you're going to become more insulin sensitive, because when you're type 2 diabetic, you are insulin resistant, meaning that the insulin just doesn't want to do its job. And so that's where medication comes into play. Okay, like metformin, where you are going to now start to be able to use, or regulate blood sugar because you're able to use it correctly and put it into the working muscles the way it's supposed to. Okay, whereas when you have insulin, insulin's job is to fuel it into the working muscles to either store it or to use it, but depending upon what situation you're in. But that's because you're insulin sensitive. That means insulin is sensitive to doing its job, if you want to just put it into the layman's terms. So, but understand that being insulin resistant, just it's your insulin's resisting its job that it has to do. All right, with diabetics, again, low impact. It depends on the severity, is really what it comes down to. But to train individuals with diabetes, it's going to be important because it's going to help them with their insulin regulation. All right, it's going to make them more prone to start, maybe coming off of medications or to be able to start seeing insulin is actually functioning correctly. But again, everything here is similar to like an overweight person, except for the fact that, like I said, it's one of those things where you got to be very particular about how far along in their diabetic path they have been, because there has been a lot of documented cases and research that shows that exercise and diet change can get individuals to come off of medications to become more healthy and they can function better metabolically on their own. Hypertension, high blood pressure. Here, this is a little tricky here. But yeah, understanding that your systolic blood pressure and your diastolic, it's one, they need to be 140 or 90 and above, all right, for you to be considered hypertensive. And then they have different levels above that. Below that is prehypertensive, and then below 120 over 80 is healthy or normal. Um, Interestingly enough, that even if you're doing some exercise, you can, it says here, you have modest impact. If you can get exercise into your system and not even have any, with minus the dietary approaches, by adding exercise in, you can drop your systolic or diastolic by about 10 millimeters of mercury. That can take you and change how you feel, number one, and it's also going to make it so that your heart doesn't have to work as hard. So, and by continuously improving that, we can continuously improve the high blood pressure. We can continuously improve the high blood pressure down so that you can become more just normotensive. Okay, so you can become more regulated, and your heart doesn't have to have that all undue stress, because what ends up happening is you have this tendency where with high blood pressure, you're going to, the heart wall of the left ventricle that pumps blood out to the body, it becomes so overworked that the walls actually grow, and they grow, and it's a negative growth. It's actually a hypertrophy of the whole muscle of the myocardium of that region versus the wall growth or the strengthening of the wall muscles that help. Okay, so there's a difference between the two. Now, resistance training, you're going to be very careful with resistance training with individuals who are hypertensive, simply because of the fact that when you resistance train, blood pressure can get exceedingly high depending upon the intensity that is used. So if you're in phases 1 and 2, the intensity level, I believe, if I'm not mistaken, it's 50 to 70% of your 1 rep max for particular lifts. That's not going to raise blood pressure while you're moving through those exercises to the highest extent that it can get to. So for those people who resistance train, it's not gonna make them get dizzy, lightheaded. It may get them dizzy or lightheaded, but it typically won't, because of the level of intensity is not progressing it that well. And then obviously with hypertension, you got to be very careful if they're on medication, which they don't have listed here. But yeah, if you have a person who is on um, high blood pressure medication, you have to be aware that at any time they can have compromise problems, and typically it's after they're done working out, because what happens is you work out, you get done, and the body typically when it recovers will drop below what your normal resting blood pressure is. So if you're on blood pressure medication, well, the blood pressure medication's job is to lower your blood pressure anyway. But when you put exercise, particularly resistance training, well, both really, into your workout plan, and then you end up doing what you have to do, well, then it'll bottom you out farther down the line of millimeters of mercury for systolic and diastolic blood pressure, and you end up passing out or having an episode, and not really good for you. Okay. Um, Mode wise, there's really not a lot of things that shouldn't be done here. I mean, with hypertension, you just got to, again, it's got to be regulated and the intensity has to be monitored. Okay. You're not going to get to those high intensity levels like you would with a regular person. All right. Similar, duration, similar assessments. Um, Static or active in a standing or a seated position. They really want you to try to avoid lying down, if possible. Resistance training wise, again, 2 to 3 days per week, so on and so forth. They want you to be a little bit more, they want you to be a little bit more aware of the isometric component of everything, because when people typically go into isometric holding, they typically hold their breath. Well, when you hold your breath, that can increase blood pressure, causing episodes as well. So just be aware. Over gripping can be a problem. Clenching of the fist can be a problem. Again, raising blood pressure, not good. Okay. And then one of the things that can, because of the effects that occur, going from sitting to standing a lot, and very quickly, can cause dizziness or fainting. So you got to be aware of that as well. So it just depends on how severe their blood pressure is, and how long they've had it for. Coronary heart disease is the leading cause of death in the U.S. For both men and women. It hasn't changed in a while. Still very, very much. I mean, obesity is creeping up there. Cancer is creeping up there. But coronary heart disease is still kind of top of the list here. So, with individuals with CHD, again, kind of like hypertension, you're going to be very aware of what medications they're taking, what they're, where are they in terms of their ability levels, and just like before, you're going to stay within that phase 1 or phase 2, all right, or stabilization and strength endurance. Okay. Um, again, it's very similar to what you saw with someone with hypertension. Not too far off of that. Again, being very careful of your isometrics. Avoid your Valsalva maneuver, holding your breath, over gripping. So yeah, This is so with people with coronary heart disease, very similar to hypertension in that respect, in that regard. Osteoporosis. Um, uh, Diminished bone mineral density. Okay. Uh, Predominantly found in females does not mean that it's not found in males. So let's make sure it's not, you have to understand that it's not just a female condition. All right. So, um, kind of, we have to keep an eye on that. And that's where I was saying before, where you can get bone mineral density testing at a facility that has a DEXA scanner, DEXA or DXA, and they're meant to check how much how much bone you have under that X-ray, and it shows you, like, if you see spots, that means that there's holes in those. Really, there's holes in the bone, because it's almost becoming more mesh-like, and that causes problems and concerns with the ability to function correctly, and brittle bone and breaking easily. All right. Also, with osteoporosis, as you age, falls can become more of a problem, because with osteoporosis, if you fall, that's usually where hip fractures come into play. Well, hip fractures are a very high cause of death for older people, because of the fact that, number one, it's not just the bone injury. Well, there's blood vessel damage, there's nerve damage that occur with that fracturing. So that is also the problem that you run into as well. But definitely need to make sure that Resistance training is put into there, even with older individuals. We got to get them to be able to try to, maintain the bone they have, and hopefully, maybe potentially get some bone turnover so you can start rebuilding. Now, if you have holes in the bone, I mean that's not gonna, regeneration is not gonna happen. So, you have to just kind of build up what you can and make the bone as strong as you can for what is there. Okay. Phase one, phase two, again, stabilization because of just the fact you don't want them to hurt themselves. And then, from falls, that's going to help promote lack of falls. And then, getting some strength back in there for some weight bearing component. Okay. Definitely going to be working on some flexibility. But it's going to be minimized um, to basically just static stretching or static and active stretching, which is still a form of static stretching. Okay. And like I said, we want to be load bearing, but you still got to be critical on what you consider load bearing. You're not going to be loading up a barbell with 300 pounds of weight and putting on someone's back, but no, there's going to be abilities and ways to load bear for individuals depending upon what it is that they're doing. So, yeah, I understand that swimming probably doesn't put as much compression on their body and maybe they don't hurt as much, but we got to get them to even do things like walk and go up and down stairs because that's load bearing. Okay. But that's not as strenuous as if they were doing walking lunges with a barbell or a dumbbell. Okay. Um, so with people with osteoporosis, especially if they're not well off, yeah, they're talking about modes being like making sure you have handrails for your treadmill. The reason why we're going to use the treadmill, or if they are able to walk normally, because again, we don't want them to fall and hurt themselves, but that's why the handrails are there. But a bike doesn't, a bike or a rower doesn't have compressive force, so we have to get them to be able to have load bearing, and so that treadmill is the best way. Swimming is the same thing. There's no load placed on the system. All right, your frequency is down a little bit. Your intensity is actually up to about 50 to 90%. So it's not you're not going to achieve 100% levels, but it's still there. Duration wise, again, kind of like with the elderly population, 20 to 60 minutes per day, 8 to 10-minute bouts if needed. So there's your static and active stretching. So just part of it there. And then the resistance training component, again, 2 to 3 days a week, upwards to 85% intensity, phases one and two, before moving on if necessary. So strength might be worth it for them because of the loading that is placed on the system. But again, everything's progressive. Um, going from sitting with no support to eventually standing is going to be optimal. All right, hips, thighs, back, and arms are critical because we want to get them to be able to have better posture and be able to move better, all around upper and lower body. But like I said here, I said it before, avoid excessive spinal loading with squatting or leg pressing. So be creative with that. Okay, and then holding their breath just because they are older might make it, is going to be a thing that you want to make sure they understand their breathing. Arthritis. Arthritis is inflammation of joints. Okay, it is the leading cause of disability among the adults in the United States. Um, so, with osteoarthritis, that's more degenerative, and so you're gonna have a degradation or a breakdown of the cartilage that also is within those joints. All right, so it can, it's gonna create massive pain, massive swelling. All right. Um, Rheumatoid arthritis, on the other hand, that's more because there's usually a fever associated with it. There's usually, the immune system is usually compromised. So what ends up happening is the body actually sends out, uh, it sends out the killer T cells and white blood cells and everything like that to help to do what it's got to do. But what ends up happening is it ends up attacking itself. So it ends up with, again, inflammation in these joint areas, and you end up with massive pain and usually, a heated up body. And so that's not a good thing as well. So You have to be aware of, arthritis is very debilitative, and movement with it is going to be very much compromised. So you have to kind of do a lot of workarounds, and you're going to have to be a little bit more lenient with scheduling, because it's like, oh, well, you were supposed to come in today. It's like, yep, I was supposed to come in today, but I could barely get up off the couch. And you're like, oh, and it's like, well, you can't fault them for that, because of the fact that they just can't move on that day in particular. All right. They do usually typically have a loss of strength. They have a problem with proprioception. Um, and then it says here they have a loss of knee extensor strength. So when you're talking about knee extensor, you're talking about that's really being able to use the quadriceps very effectively. All right. Um, Joint pain and stiffness are definitely there. And because of that, you're going to have a lot of inactivity. So therefore, you're going to end up with muscle mass loss. And then flexibility is also going to be compromised. So that's why sometimes you might see deformity in somebody who has arthritis, because they're so contracted, um, and then they can't stretch, so that you're not being able to maneuver them like in the way that they're supposed to be. And then other things like being able to function correctly, being able to move independently, and then a loss of balance. So you got to be very particular with the exercise selections that you use with them. Okay, so this is going to be one of those where you're going to have to definitely pay attention to a lot of research to dictate what works well with these individuals, or find case studies where people have had really good success with people with arthritis. But again, not everybody always responds in the same manner. Okay. Again, this is going to vary per person, because like I said, it depends on what the person's symptoms are. No two people are alike with the symptoms. So a treadmill for one person might not be a treadmill for another. Stationary cycling, rowing, like those are low impact. All right, they're not compressive, so those might be more beneficial. But again, a rower might not work, because even though they're low impact, they can't grip onto the handles maybe. So it just depends on what it is. Okay. They can't, they can still do work. It's not, you're not going to minimize them to that extent, but you can see here that a lot of the things are very much the same. The intensities are still up. Flexibility again is, self-myofascial release, static and active stretching. So we're going to get them to try to open up, to stretch out. And then, 2 to 3 days a week in the, varying reps and sets. And then particularly you're going to stay in that phase one with reduced repetition counts. So, but you can always change the intensity by giving them more of a circuit, um, or peripheral heart action, which is more about getting the heart rate to recover fully before you go on to the next one. All right. Heavy lifting and high reps are not going to be tolerable. What you're looking for is pain-free movement. Again, you're going to use whatever is tolerable. They say, self-myofascial release should be tolerable, or what's tolerated. Well, everything at this point is going to be tolerable for them. Is what they can do. Okay. Cancer. So we talked about coronary heart disease. Cancer is the second leading cause of death. About It's kind of crazy. 44% is a potential for 44% of men and about 38% of women across their lifespan to potentially develop cancer. So we got to try to do whatever we can to help our bodies function correctly, internally and externally, so that we can try to avoid, cancerous tumors occurring. But again, you can do everything that you want to do, and you can be as healthy and clean as you want to, and you might be, you know what I mean? It's just, you never know. You just never know. And obviously there's a genetic predisposition to this. That's why there's always questionnaires about it. So we just got to be aware. Okay. Awareness is obviously key. So when it comes to recovering from cancer, it's really kind of, it's going to be more of a tolerance factor, because after things like chemotherapy, there's been some really good studies that show that research has shown that using exercise as a tool after chemotherapy has improved quality of living afterwards. So that's a big deal. Okay. And really it's going to be as tolerated by the individual, because there's chronic fatigue, there's other weakness, there's atrophy. All those things are going to occur because of the fact that you just it's really it took its toll on the body. All right. Now, as far as guidelines are concerned, um, you know, there really isn't. Again, it's usually low impact stuff. It's again what's tolerable. The intensity is definitely down. Definitely down to 50 to 70% of your heart rate reserve, so it's gonna be lower. Session wise, it's gonna be less because it's gonna and start low and build up is always the critical part with working with cancer individuals. Flexibility wise, I mean, keep them close to the continuum. There's no flex, but again, it's as tolerated. And then 2 to 3 days a week, varying sets and reps. Again, progress appropriately. Avoid heavy lifting early on. Make sure that you add enough rest into your sessions so that they can fully recover. Everything's as tolerated. Self myofascial releases, because typically they may be sensitive. Their muscles may be sensitive due to the chemotherapy. And then, like I said, you start to build up. Start high to low. Okay. Pregnancy, on the other hand, gets a little bit treacherous because, let's see, the best way to put it is, if you're an individual who is pregnant and you have not worked out previously, then you probably should not be starting up an exercise routine, because it puts undue stress on the fetus. All right. If you're a person who's worked out previously to getting pregnant, then you should be able to continue. And doctors are very good about telling their patients about that. So it shouldn't be something that's new and surprising to a pregnant woman if they ever came to you and said, "Hey, I'm looking at starting my training up." It's like, "Well, have you ever, worked out before?" "No." And you're like, "Well, this is unfortunately, I'm going to need the doctor's clearance before I can start you on any sort of regimen." Okay. So that's one of the things that we want to be aware of. Okay. Um, so we need to make sure that we pay attention to that, and we have to ask that. Um, let's see. In terms of you know the benefits of it, well, yeah, there are a lot of benefits to the mom and the baby. Okay. And they're going to be very appropriate and very important that we see those. But we have to, again, make sure that you're not pushing the female too hard, that there can be challenges with the pregnancy. So there's certain times that you want to include certain things. There are certain times where you want to take away certain things. So going from like those you know uh, prone positions where you're got the stomach down toward the ground, that's going to eventually change after usually about 3 months after the first trimester. Getting onto their back, that's usually going to change as you start moving into the second and third, because it gets harder to move off the floor. So there's a lot of things that are going to come from this that you have to pay attention to. But you're going to understand too that flexibility is going to change, center of gravity is going to change, strength is going to change, because you're working now for two. All right, core musculature is going to change, because now you're trying to you're going to have this massive change in your belly. And then pelvic floor musculature and the pelvis itself start to become a little bit changed, because hormonally the pelvis girdle itself actually starts to loosen up, which makes the joint areas down there more lax, meaning they're going to there may be some more pain down there than typical, because everything is starting to stretch or open up, or the joints themselves, the bones themselves are becoming a little bit different than what a typical female day to day is, because it's prepping for the pregnancy. Okay. And then obviously postpartum is very important. So we got to be very careful of that. I mean, I know females that have trained all the way till they were 8 months pregnant, and they didn't have any complications, but that's not everybody. So it's going to be as needed, and it's going to be what the, obviously under massive doctor's orders. So you got to pay attention to that. So it's, and again, long sessions may not be appropriate, but again, what is it that the female came to you at? What level of health? Were they a very high exerciser? Were they a low exerciser? And then you can adjust accordingly. Okay. But again, avoid exercises in a prone or supine position after 12 weeks. Now that varies depending upon the doctor or recommendations. So typically, we we were always taught that it was after 3 months, no more stomach down, or not like, and I don't mean on the stomach, I mean just facing the floor. And then after as tolerated at that point, 4, 5, 6 months, depending upon how much growth of the stomach you get at that point. Chronic lung diseases. Now, this can get a little treacherous with VO2 because now you're talking about oxygen uptake concerns, but you're talking about lung disease, lung disorders. There's a lot of complications that can occur with it. Airflow problems, like with, chronic obstructive lung disease, shortness of breath or dyspnea, and so shortness of breath causes that fatigue. So there's a lot of things that come from this, and so therefore your capacity to do more work is diminished, and you end up having shorter bouts of exercise, and the intensity levels just can't do their job. So what do we work for? We obviously try to work with the diaphragm and breathing exercises and everything like that, but that's very challenging. Okay. In terms of exercising with those with lung disease, now also you can also consider, asthma is also something in there, but that's as tolerated, and depending upon how severe it really is. Okay. Let's see. I mean, really, there's not much that is changing in terms of the modes. Frequency is about the same, as most other conditions that we've talked about. Capacity is that intensity is way down just because they can't handle it. Durations are down because it's a lot of it's again what's tolerable. All right. But again, upper body is typically going to be more of a concern because it's going to cause more chest. It could potentially cause more chest pain, or not chest pain, but it really can be more chest pain. But also, it's going to be the shortness of breath that comes from that. So, and then it's going to be that's tolerable, or it needs to be monitored. So you got to be careful of what you're doing at that point. All right, and then vascular, peripheral artery disease is, that's one of the things here. Intermittent claudication, that's again that comes with peripheral arterial disease. So what ends up happening is you end up with narrowing of arteries, and so therefore you end up with blood supply that's diminished to specific areas, particularly that of the lower limbs. So you got to be careful with with what you're programming for these individuals, because it can become very compromised in what they're doing. So that's one of the concerns that we have to be aware of, and just because of that narrowing, it really can become challenging on a person. Now, let's see, clearance is definitely going to be optimal. At this point, you're going to definitely have to have a sign off on that. So you got to be very careful with what you're doing with them, and as long as the doctors are okay with that. Now, I definitely follow the progression that you need to for within the OPT itself, but it's going to be very challenging because it's going to be hard for intensity buildup because of the fact that you have like intermittent claudication. What we're talking about there is, you're basically getting, it's pain that is associated with like, with the movement that you're doing. So typically you can have anything from a cramping effect with that. You can have loss of limb function, well, numbness, I guess would be not so much loss of limb function, but and you're gonna have, you may end up with more fatigue than you want to. So it's one of those things where you have to constantly pay attention to it, because you have to constantly pay attention to it because it's not because of, as it says, it's intermittent. So that means that it comes and goes. So it can go from light to bad to not feeling anything to feeling worse. So there's always something that's going on with there. So you got to pay attention to that constantly. But if it's vascular, we know there's a problem with blood flow. That's really the name of the game there. So got to be very careful, and you have to give shorter bursts of exercise duration than typical. Okay, so just got to be very careful as to what you're doing, and progression is going to be key, and then self-monitoring and trainer monitoring are obviously going to be key at that point. Okay, so these are just some of the special populations that are out there. They're not an exhaustive list, but these are some of the main ones that you're probably going to run into on a more common basis, and that's typically because there's more prevalence of them than anything else. Okay, but it's definitely something that you have to pay attention to and focus in on so that you can understand what's happening in those moments. Okay, so chapter 16 here, another one down, and we're going to keep cruising along here. So have a great day, and hope to hear from everybody soon.